So, ladies and gentlemen, I would like to conclude that by preserving the ST junction itself and especially the ratio of ST junction to annulus close normal range, the trapdoor technique will not be a significant risk factor for aortic dysfunction in arterial switch operation. Thank you for your attention.
Thank you for your talk. The invited discussant is Dr. Sakamoto.
Thank you very much, Chairperson. So, several Sakamoto from Shizuoka Children's Hospital. First of all, let me say also, congratulations for your good result, and thank you for your important information. And basically, I agree with you. Your consideration of maintaining the normal balance of neo-aortic root can be a critical factor for reducing neo-aortic regurgitation. We believe that. In the previous paper, you presented that Dr. Formigari said the patient with neo-aortic regurgitation usually have an elongated neo-aortic root with a flattened and distally displaced ST junction. And many of them had trapdoor technique in their study cohort. They concluded the trapdoor technique is a risk factor, possibly because of distortion of the ST junction geometry. You said that. And another report from Boston group, Dr. Schwartz commented, 2 surgeons in earlier time period had lower risk than others in later time period. These findings may be attributable to a change in surgical technique. Perhaps using larger buttons for coronary transfer. Undoubtedly, surgical technique for coronary transfer must be a big key to reduce neo-aortic regurgitation. By the way, I usually transfer the coronary transfer button to suprasinus position, not to cut the line of ST junction, even using trapdoor technique, because of not to deforming the ST junction and aortic geometry. However, every technique can have both merits and demerits. And so, I would like to ask you about surgical techniques and its related issue. First, could you tell us the technical points in your arterial switch operation which seem to be effective for maintaining ratio of ST junction to annulus? Using trapdoor technique, you said, together with cutting the line of ST junction. That's the first question.
All right, thank you, Sakamoto. I understand 2 points in your question. One was about my idea about the supracoronary, above commissural transfer, the coronary transfer, and another one is what is my technique maintaining the ST junction and the ratio in a more or rather a normal range. Well, the second, I prepared answer slide. I would like to remind you that Dr. Kunzelman's paper, he expressed that the size of ST junction and base should follow the normalized root dimensions. So, this is my suggestion. Left side is usual trapdoor technique. It will increase the sinus and ST junction. But I prefer like this inclusion. You can trim the coronary curve, and below that the sinus to root junction incision, you can make like this. Then we can reduce, we don't enlarge the ST junction circumference, and we hope less dilatation of sinus. This is my usual technique. And another one is many surgeons will adopt the posterior sinus, non-coronary sinus after at the neo-ascending aorta. We can reduce that non-chronic sinus a little bit, if in a very large circumference. So I would like to 2 points. And about your first question, about commissure transfer is very important technical option for congenital cardiac surgeon to manage the TGA, especially for very unfavorable coronary artery management. But it is very useful. But we can guess from normal anatomy, aortic valve and sinus can protect the coronary ostium from high pressure during systole. But if we make supracommissure ostium, it will lose the normal protective effects from valve and sinus. So I don't know, but we have to follow long-term results in that technique. Anyway, it's a very good option.
And that's a merit and demerit. And you're also trying almost between the classical and punched out. Yeah. And the second question. So please inform us outcomes in your technique of supra-aortic stenosis and coronary events in your study cohort.
Yes, I have, in this cohort, I have 10 reoperations. It was mainly right side obstructive lesion, and as I showed, 2 cases of aortic valve replacement and plasty. Another one was mitral cleft repair. And I'm lucky not to have any supracoronary stenosis or coronary event, but in our hospital, not yet, we do any coronary angiography in total cohort. So anyway, we don't have any symptomatic coronary event.
Thank you very much. I can conclude.
Thank you.
Just have a question for you. I belong to this group of people who question the use